Okay, so afternoon or good morning rather. We'll continue our lecture, topic tutorial series as we look at local anesthetic agents. Obviously, we have come across the use of local anesthetic agents in theater, and I'm sure you've been given a lecture before. So this is just to supplement whatever lectures you've been given. So by way of introduction, local anesthetic agents are those medications that produce transient loss of sensory, motor, and autonomic system function in a discrete part of the body. All right, two things that you must remember is that it produces a transient loss in a discrete part of the body. So it's unlike general anesthetic agents that produce a global anesthesia, global loss of sensory, motor, and autonomic system. All right, how do these agents work? They reversibly inhibit transmission, nerve transmission, by binding to sodium voltage-gated sodium channels in the nerve plasma membrane. All right, when they bind to these voltage-gated sodium channels, they render the membrane impermeable to further sodium ions, and this inevitably prevent initiation and propagation of action potential. All right, that's how they work. They bind to voltage-gated sodium channels, and while this is going on, they render the membrane impermeable to sodium ions. And sodium ions need to go into the nerve membrane in order to initiate and propagate action potential and nerve impulse transmission. And this is a structure, all right? A local anesthetic, if you look at this diagram, has three components. It consists of a lipophilic aromatic group, the benzene group. It has hydrophilic group, which is the tetraimine group, and there's an intermediate chain. This intermediate chain determines the nature of the local anesthetic agent, whether it's an ester or an amine. Okay, now local anesthetic agents are weak bases, and they exist in solution both the charged and uncharged forms. The lipophilic ring leads to greater lipid solubility, and this is how the agent rapidly permeates the nerve membranes, while the hydrophilic end binds with greater affinity to sodium channel. So the proportion of the charged and uncharged forms of local anesthetic agent, which determines their mechanism of action and the onset of action, is determined by the pKa of the drug. All right, pKa that's close to plasma pH will favor more uncharged forms of local anesthetic agent, all right, which helps it to bind reversibly to the voltage-gated sodium channel in the nerve membrane. All right, potency. All right, these are things we can use. How do you enhance the potency of a local anesthetic agent? By now, you know I like mnemonic. So use the word heal by the addition of a highlight group. All right, if you add a chlorine or a chloride or a fluoride group, it increases the potency of the local anesthetic agent. If you add an ester group, all right, or you add an alkyl group such as CH2, all right, and increase lipid solubility, these are the factors that enhance the potency of local anesthetic agent. All right, lipid solubility, the addition of the alkyl group, addition of an ester group, and addition of a chloride or a fluoride group, or even a bromide group. All these are factors that increase the potency of local anesthetic agent. The onset of action is also determined by some factors, all right, which are called MAP, the medium in which the local anesthetic agent is being injected, all right. If you inject the local anesthetic agent into an acidic medium, for instance, a septic spot, it will slow down the onset of action. But if you add bicarbonate, making it more alkaline, the onset of action of the local anesthetic agent is enhanced. All right, additives such as adrenaline, all right, makes local anesthetic more acidic and it slows down the onset of action. All right, and slowing down the onset of action kind of helps it. So with the use of additives like adrenaline causing vasoconstriction, it kind of prolongs the duration of action. Listen, additives like adrenaline will slow the onset of action, but it will prolong the duration of action. The pKa of a local anesthetic agent is the primary determinant of its onset of action. Like I mentioned before, local anesthetic agents with a pKa closer to physiological pH will have a faster onset of action. Duration of action, all right, this can be affected by protein binding. All right, the more protein binding activity of a local anesthetic agent, the longer the duration of action. All right, liposomal encapsulation of a local anesthetic agent also prolongs its duration of action. So how do these local anesthetic agents get metabolized? It depends on the type. The ester LAs are metabolized by pseudocholinesterase, except for cocaine. Now, this is a likely multiple choice question or single based answer question. All ester local anesthetic agents are metabolized by cholinesterase except, all right, cocaine. Okay, will be the answer. All amide local anesthetic agents are metabolized in the liver by macrosomal enzymes, and they are slower than ester metabolism. All right, anesthetic concentration, you are most often have seen this, and this is important for you to understand. The concentration of local anesthetic agents is actually expressed as a percentage, all right, which is measured in grams per 100 mils of solution. For instance, if we say 1% lidocaine, what does that mean? It means it contains 1 gram of lidocaine in 100 ml solution. All right. Now, invariably, it means 10 milligram per mil. So 1% lidocaine is equal to 10 milligram per mil. Just add 0 to it. 2% will be 20 milligram per mil. An easy way to calculate the milligram per mil concentration from percentage is by moving the decimal point 1 place to the right. For instance, is 0.25% bupivacaine, the milligram per mil strength will be 2.5 milligram per mil. Lidocaine, like I mentioned before, 1% lidocaine will be what? 10 milligram per mil. Just move the decimal point to the right and you have the milligram per mil concentration of your local anesthetic agent. So, for instance, who is there? Let me see who is on here. For instance, Mary Kay, if you have 0.5% bupivacaine, what will be the milligram strength of that solution?
Doctor, you said 0.5?
Yes, 0.5% bupivacaine. What will be the milligram per mil strength of that agent?
5 milligram per ml.
Beautiful, 5 milligram. Okay, so don't forget that when especially we use bupivacaine a lot for spinal anesthesia. So when they tell you, oh, we're using 0.5%, it will come to your mind that, oh, this medication is going to be given at 5 milligram per mil. All right. And a lot of times for CS, we go between 10 milligram or 12 milligram. All right. So you understand what I'm saying? So if you say, if we're on call together, Mary Kay, and you have a CS, and you tell me the woman is of a short stature and all that, I will say, Mary Kay, please don't use more than 20 milligram of per mil, 20 milligram per mil of bupivacaine. You understand what I mean? So I'm asking you, so it depends on the percentage dilution that you have. Do we understand that, everybody?
Yes, doctor.
Okay. My laptop, okay. All right. Local anesthetic agents are not without toxic effect, and the systemic effect of local anesthetic agent is actually, um, measured in terms of what we call the CC-CNS ratio. The CC-CNS ratio. It means cardiovascular collapse over central nervous system effect. All right, and is defined as the ratio of the drug that is required to cause a catastrophic cardiovascular collapse to the drug dose required to produce seizure. So your CC-CNS ratio refers to the ratio of the drug that's required to cause cardiovascular collapse to the ratio of the drug that is required to cause CNS ratio. So what does that mean? A low CC-CNS ratio is associated with more cardiotoxic agents, isn't it? Why agents with higher CC-CNS ratio will have a greater safety of margin. So if there's a new LA that is being introduced, or you have different local anesthetic agents at your disposal, and you want to find out which one you use, you want to consider the CC-CNS ratio. The ones with the higher CNS ratio, all right, will have a greater safety margin. For instance, ropivacaine and levopropivacaine have higher CC-CNS ratio than your normal propivacaine. So they are safer, all right, with considering their systemic effect. All right, local anesthetic agent can have a multi-systemic toxicity based on the organ system that is affected. For the central nervous system, you can have psychomotor numbness, dizziness, blurred vision, tongue paresthesia, tinnitus. Okay, most of the time psychomotor numbness is the first to develop. In cardiovascular system, you can have arrhythmia, and you can have circulatory collapse. Respiratory system will give you reduced hypoxic drive and apnea. Immunologically, esters LA induce allergic reactions, all right, because they're derivative of P-amino benzoic acid. All right, so if you have a question, which one produces more immunological side effect? They are the esters LA. When there's an inadvertent intravascular injection of a local anesthetic agent, all right, you have signs of what we call LA toxicity, all right? And I put it here: lightheadedness, agitation, tremor, tingling sensation around the mouth, convulsion, slurred speech, coma, and cardiac arrest. These are signs of LA toxicity. Now, management includes early recognition. You want to recognize it early. You've given a spinal to a patient and said, I'm feeling lightheaded, or is having tremors, tingling sensation around the mouth. You need to know that, oh, this is most likely an early toxicity. So you discontinue the injection, you call for help immediately, and ensure that you maintain the airway and give 100% oxygen. If seizures have developed, you want to control the seizure with your benzodiazepines and immediately obtain blood for analysis. Now, the agent of choice for management of local anesthetic toxicity is your lipid emulsion, all right? It's a bolus, you give a bolus or IV bolus of 20% lipid emulsion at the rate of 1.5 ml per kg over 2 minutes. After your bolus injection, you want to give infusion at 15 ml per kg per hour, and you can actually repeat bolus administration twice, all right? But you must give at least 5 minutes interval. Repeat infusion at 30 ml per kg per hour until there's cardiovascular stability. Okay. So if I ask you, a 24-year-old male patient presented for below knee amputation, all right, and it was to be done under spinal. Immediately after, the patient had the spinal anesthesia and was returned supine. The patient became lightheaded, and became agitated, and they start complaining of tingling sensation around the mouth. A, what is your immediate diagnosis? 2, outline your management of this patient. Okay, you should be able to answer that. All right, who is on here? Let me see. There are no names. These are just okay. Chalize. Sorry, pardon me the pronunciation. Did you hear the question? A 24-year-old male patient presents with a below knee amputation, and immediately after spinal was given with 0.5% bupivacaine. Patient started complaining of being lightheaded, agitated, and with tingling sensation around the mouth. What is your immediate diagnosis for this patient? Chaliza. He's not here. Anybody can answer the question? Anybody, so that we don't take time? Is Chaliza
I'm
there?
not sure, doctor. I
Okay,
was at
go
the
ahead.
hospital. I just joined. I was on call, so I just joined the meeting. I'm not sure now.
The
What's
answer. Call
Yes,
your best
doctor.
friend. Call your best friend.
Maybe Marika can help me.
Ah, you are the best friend of everyone. Okay.
Yes, doctor.
Go ahead.
So, doctor, we would diagnose the patient with local anesthetic toxicity.
Beautiful.
And the plan that you'd follow is early recognition of the toxicity, so the lightheadedness, agitation, and the tingling sensation around the mouth. Then you'd discontinue administering the local anesthetic, call for help. Then you'd maintain the airway by positioning the patient and putting the head in, opening the airways by positioning the head, and give 100% oxygen. Then you want to control the seizures with benzodiazepines, and then obtain blood for analysis. And then administer a lipid emulsion. So first the bolus of 20% lipid emulsion at 1.5 ml per kilogram over 2 minutes, that you can repeat, but only after 5 minutes. So you can repeat it once. Then you do an infusion at 15 ml per kilogram per hour.
Yeah, which you can also repeat at 30 ml per kg per hour until cardiovascular stability. Correct. All right. Chalisa, did you hear that now? Your friend has helped you out.
Yes, thank you very much.
You should buy her lunch. All right, examples of local anesthetic agent. Like I mentioned, local anesthetic agent, the type is determined by the intermediate ring that combines both the lipophilic and the hydrophilic ends. So we have amides. Examples are lidocaine, mepivacaine, prilocaine, and all that. One simple way to differentiate between amides and ester local anesthetic agent is I look at the table before you. There's always an I before the cane in the amides group. Can you pick it out? There's always an I before the cane. Did you see that? Did you see that, Chalisa?
Yes, doctor.
Yes.
Okay, you can see that there's always an I before the cane in amide. So if they said the following local anesthetic agents are esters, except, just look for I before the cane, and that will be the answer. Do we understand? It's simple, isn't it? All right. I just wanted to just mention some of these things to you. Examples, the common ones are lignocaine or lidocaine, which is an amide. All right. The maximum dose depends on whether you're having the adrenaline vasoconstriction or not. The addition of vasoconstriction will increase the maximum dose that can be given. All right. Maximum dose of lidocaine without vasoconstriction is 3 to 4.5 milligram per kg. But with vasoconstriction like adrenaline, you can actually increase it to 6 to 7 milligrams per kg. Onset of action is 1 to 3, is independent of the vasoconstriction, and duration of action is actually longer, like I mentioned to you, if you have vasoconstriction. We actually use additives vasoconstriction to prolong duration of action of the local anesthetic agent. All right, use of lidocaine includes local skin infiltration. You can have intranasal or ultra-oral spray before endotracheal intubation. This helps to minimize laryngeal or pressor response to your intubation. Lidocaine can be contained in dermal patches, especially to reduce pains due to shingles. All right, ophthalmic drugs for short ophthalmic procedures. Lidocaine can also be used with cough preparations to suppress cough. Antiarrhythmia. All right. If you have a question, which of the following local anesthetic agent can be used as a class 1B antiarrhythmic drugs? We are talking about lidocaine. Can be used for nerve blocks, epilepsy as a second line treatment after the phenobarbital has failed. So if I ask you, mention 7 uses of lidocaine, you just write lidocaine and begin to fill in the gap, okay? Bupivacaine is a common local anesthetic agent that we use, also known as Marcaine. All right, it's an amide, just like lidocaine. All right, it has a longer side chain. All right, it exists as a white crystalline base with a melting point of 251 to 258 degrees Celsius. It is not soluble in water, but it's soluble in acid. And bupivacaine hydrochloride is slightly soluble, which is the form that is used in theater. It is about 95% protein bound, and don't forget that increases duration of action. And being an amide, it is metabolized in the liver, all right, with conjugation of glucuronic acid. Its major metabolite is 2,6-pipexcolocylidine, all right, which is mainly catalyzed via your cytochrome 450 in the liver. Of the metabolites, only 6% of it is excreted or changed in the urine. Most of them are excreted, all right, in the urine, but only 6% is excreted unchanged. Yeah, you have half-life of 2.7 hours in adults, and it can actually be as high as 8.1 hours in units. It comes in different concentrations, 0.25%, 0.5%, 0.75%. And in labor analgesia, you can actually double dilute your 0.25% to 0.125%. All right, the idea is it helps, to have more of sensory blood than motor blood. Uses include the ones I put there. So the two common agents we have, I can ask you to compare lidocaine and bupivacaine. All right. For lidocaine, the onset of action is short as compared to bupivacaine with a longer onset of action. All right. Duration of action is also short compared to prolonged duration of action of bupivacaine. Bupivacaine is more protein bound compared to lidocaine. And toxicity, all right, lidocaine causes more CNS, while bupivacaine causes more cardiovascular toxicity. All right. Are you ready for these questions? Let's quickly answer these questions. Who is there? Let me see who is there. Read the question and you answer. Who is this 060504003? Ask the question and answer. And the whole class will know whether you are correct or not. Anybody, quickly.
So the first question, which of the following local anesthetic agents is not an ester? So the answer is A, cocaine.
What? What's the answer?
Oh no, it's Prolocate, sorry.
Prelocaine.
Yes, doctor.
That's C.
Yes.
Huh?
Yes, because
Yes. Why?
because there's an I, so it's an amide.
Beautiful, beautiful. Next person answered, ask second question and answer it.
Number 2, what is the milligram per moles of 0.25% bupivacaine? So it is 2.5 milligram per mole.
Correct. That's B.
B.
How did you get your answer?
You move the decimal point 1 point to the right.
Beautiful. Who is that? Who's that?
Mareike, doctor.
Oh, okay, okay. Third question, anybody? Anybody thought question? Viscous, you are not talking today.
Sorry, doctor, I am here. So the third question, all ester local anesthetics are metabolized by plasma pseudocholinesterase, except, and the answer is A, cocaine.
Okay. Beautiful, beautiful.
Thank you, doctor.
All right. Okay, these are questions you can attempt. All right. When I send the slide, you already have the slides, isn't it? So, anybody want to answer first question concerning local anesthetic agent? Describe the mechanism of action, then enumerate the factors that affect the onset of action. Anybody? Anybody? Two one zero 2017 03242. You want to answer?
Dr. I'll answer it along. The mechanism of action of local anesthetics is that they bind reversibly to voltage-gated sodium channels in the nerve plasma membrane of nerves, rendering the membrane impermeable to sodium ions, therefore preventing the action potentials from moving.
Beautiful. Good.
And then enumerate 4 factors that affect the onset of action. So that we can remember by the mnemonic map. So M is the medium. So if you inject the LA into an acidic medium, there will be a slower onset of action, and in an alkaline medium, a faster onset of action. Then the A is for additives such as adrenaline that makes the LA more acidic, and there's a slower onset of action. Then the P is the pKa. So if a local anesthetic with a pKa closer to the physiological pH will have a faster onset of action. Beautiful. And then the fourth one, I'm not sure of, doctor.
Okay, great try. Second person, anybody to answer second question?
Yes, doctor, I will answer. So the question is regarding local anesthetic toxicity. A, list 4 signs of LA toxicity, and then B, list the management of local anesthetic toxicity. So with local anesthetic toxicity, initially the patient might feel agitated, or you may notice that the patient becomes agitated, and they may complain of tingling sensation around the mouth. They may also have a slight tremor. Along with that, lightheadedness and slurred speech if it progresses. So those are 4, but if it goes on further than that, the patient may have convulsions or coma or even cardiac arrest. So with the management, it's important to notice these signs early. And then if it's a continuous injection that you are giving still, or if it's an infusion, it's important to stop it. Call for help, and then maintain or establish airway patency and maintain it. So positioning, if the patient is not intubated and needs intubation, intubate, give 100% oxygen. If the patient is seizing, control the seizure with benzodiazepines. I think we use diazepam. And then you have to obtain blood samples for analysis. So to establish the extent of the toxicity, so mostly LFTs. And then you administer a lipid emulsion like Marek explained.
Beautiful, good, good. Yeah, so I'm happy that at least you got all the things I said today. All right, any question on this? Do you have any question? Any question? No question? Let's see if we can do the next one more. Let me see. Where are you? Where are you? Let me see. Have you done acid-base balance recently?
No, doctor, not recently.
Okay, let's see if we can quickly run over that. I can't seem to see it here. I can see. Are you seeing my screen?
Not yet, doctor.
I'm trying to look for, okay. Are you seeing this one?
We can see your file explorer.
Well, you can see acid-base balance. What's up now?
No, doctor, we can't see the presentation.
Let me see. Share screen. What about now?
Yes, doctor, now we can see. Thank you.
Okay. I remember I was one that taught you this in your year 4. Isn't it? You remember?
Yes, doctor.
All right, so acid-base balance refers to the maintenance of a stable body pH in body fluids, which is necessary for normal enzyme activity, ion distribution, and protein structure. So when the body pH is not within normal range, we have abnormal enzyme activity, abnormal ion distribution, and we can have a breakdown of protein structure. The normal blood pH is normally maintained between 7.35 to 7.45 equivalent, which is equivalent to hydrogen concentration of 3.5 to 4.5 nanomole per liter. So when we're talking about pH, an increase in pH refers to acidity, and the lower the pH, the more acidic the solution is. A higher pH is alkalinity. All right, the lower it is, the higher it is, the more alkaline the solution is. Okay, and don't forget your Heisenberg equation. All right, and this is where we see that pH and pK are related. But don't forget, in all of this, your pH is a function of the ratio of your bicarbonate and your PCO2. And this is important. In all of this equation, what we are driving at is to show you that pH is a function of the ratio of your bicarbonate. You can see from this, pH 6.1 plus logarithm of bicarbonate over PCO2 times 0.3. All right, there are different ways, to respond to acid-base challenge. and one of them is the buffer system. All right, when there's a change in pH, whether towards acidity or alkalinity, there are buffer system, all right, that helps to limit the change in the pH and the effect of it. All right, we have two types of buffer system. We have the bicarbonate buffering system and the non-bicarbonate buffering system. Well, the buffer system is limited because it only provides a temporary solution to the challenge. It does not eliminate hydrogen ion, and the supply get easily exhausted. So the second way the body responds to acid-base changes or challenge is by initiating a compensatory system, which can actually be respiratory or renal. All right. So if the problem is metabolic, the respiratory system will try to adjust to compensate for it. And if the primary disorder is respiratory, the metabolic system will also want to make some changes to reduce the effect. And we have metabolic compensation. All right, buffers are, buffers in tissues and blood minimize the increase in hydrogen ion concentration. And we can have extracellular and intracellular buffers. All right, this is the carbonate system, all right, which combines with, when carbon dioxide enters the blood, it combines with water to give you carbonic acid, which differentiates to give you hydrogen ion and bicarbonate. All right, sodium comes in to replace the hydrogen ion and it forms sodium bicarbonate. By so way, you reduce the change in hydrogen ion. Don't forget that it cannot protect against changes in pH that is due to PCO2. Hemoglobin is another buffer system in the blood, which helps to reduce the impact of your acid-base changes. Carbon dioxide will diffuse across red blood cell membrane, and this will combine with water and all that. By so doing, when sodium binds with your bicarbonate, hydrogen ion is buffered, and hemoglobin actually helps to prevent changes in pH due to change in PaCO2. And while bicarbonate helps to prevent change in pH that is due to bicarbonate change, which is metabolic. All right, like I mentioned before, when the buffering system fails, you will now have what they call the compensatory mechanism, which can be respiratory or renal. All right, and the relationship here is based on the fact that the lung has a capacity to excrete as high as 15 to 20,000 millimole of hydrogen ion per day. All right, because because of breathing and out and all that. So therefore, we have hyperventilation with flow of carbon dioxide, and that will lead you to respiratory alkalosis. Why hypoventilation will lead to accumulation of carbon dioxide that will give you respiratory acidosis. All right. Now, similarly, if there is metabolic acidosis, the body wants to hyperventilate and having to blow off carbon dioxide to reduce the acidosis that you have. So you can have reduced PCO2 in order to compensate for the metabolic acidosis and vice versa. The kidneys excrete about 60 to 80 millimole of hydrogen ion per day. It's a slower way of maintaining acid-base balance, all right, and compared to what you have in the respiratory system. So by regulating the amount of bicarbonate that is reabsorbed in the proximal convoluted tubules, you can have about 80 to 90% of the bicarbonate that is filtered being reabsorbed, all right, in the proximal convoluted tubule. And this is how it helps, all right, to maintain acid-base balance. So disorders, like I mentioned, disorders could actually be either acidosis, when you have a low pH, it could be alkalosis, when you have a high pH. You can have simple acid-base disorders, when you have single primary etiological factor, which could be either respiratory or metabolic. Then you can have mixed acid-base disorders where the primary disorders, two of them can be present at the same time. So you can have either metabolic or respiratory acidosis at the same time. So it gives you a mixed picture. Respiratory acidosis occurs when there's an abnormal process that tends to cause a change in PCO2. All right. Now, if the PCO2 increases, you have respiratory acidosis. If PCO2 is reduced, you have respiratory alkalosis. In the same way, metabolic, all right, the change in pH is as a result of change in primary change in bicarbonate. So when you have reduced bicarbonate, you have metabolic acidosis. And when you have high levels of bicarbonate, you have metabolic alkalosis. All right, I mentioned this before to you. Let's see. All right, in order for you to, where did I put it? In order for you to, all right, how do you assess acid-base disorder? When you have an ABG picture, they said, oh, because I need an ABG for this patient before we start mechanical ventilation, and you do arterial blood and you bring the ABG result. How do we check? So number one, we look at the pH, isn't it, to determine whether this is acidosis or alkalosis. All right. Then once you make up your mind whether it's alkalosis or acidosis, you want to check for the PCO2 and the bicarbonate. Why? To determine what the primary problem is. Now, this way you use Rome, R-O-M-E. I taught you this, so I'm just trying to make you remember. R-O-M-E, you know, is to use to determine the primary disorder. For respiratory, your pH and your PCO2 will go in opposite direction. R, respiratory opposite, ME, metabolic equivalent. Okay, so respiratory, if you look at it, your pH and your PCO2 will go in opposite direction. If your pH is high and your PCO2 is low, all right, you know that you're having respiratory alkalosis and vice versa. For metabolic, your pH and your bicarbonate will move in the same direction. If your pH is low and your bicarbonate is low, it's metabolic acidosis. If pH is high and your bicarbonate is high, that is metabolic alkalosis. So the primary disorder is determined. You can use the mnemonics Rome to help you. After you have determined your primary disorder, then you look at the PaO2 to determine oxygenation. All right, and don't forget, in interpreting your acid-base balance, we use absolute value. Let me see whether it is here. Yeah, I wrote it here, so you have it in your slide. All right, we use absolute values. Okay, we don't use the range. So in our assessment of your acid-base balance, the pH is 7.4. PCO2 is 40. PaO2 is 95. Base SS is plus or minus 2, and your bicarbonate is 24. So if you have, let's see if I have an example here. Okay, guys, who will take a go at interpreting this ABG? Mr. AO presented to the emergency room with the following ABG results. pH is 7.5, PaCO2 is 28, and bicarbonate is 24, with a PaO2 of 54. Who will take a go? Who will try to interpret this ABG result from all I've been speaking? Anybody? Just try. Anybody try?
Okay, doctor, so that
Yes, Mary Kay. Thanks for always coming to my aid.
Thank you, doctor. So the pH is 7.5, so it's high. The normal 7.4. The
So what does that
PaCO2,
tell you? Is that acidosis or alkalosis?
it's alkalosis.
Alkalosis, beautiful, okay.
And then the PaCO2 is down. The normal is 40, and now it's 28. And then the HCO3 is usually 40. So this one
It's low.
it's low. It's
Okay.
usually 24, or HCO3 is usually 24, so it's normal.
The HCO3 is normal. And then PaO2?
The PaO2 is usually 95, so it has gone down.
So,
So
what is
therefore
your,
it is.
yes, go ahead. What's your interpretation?
A respiratory alkalosis. It's because it is opposite.
Respiratory alkalosis with what? Hypoxemia, isn't it? Because the PaO2 is low.
Okay, with hypoxemia, I understand.
You don't just say you must put your oxygenation status into your interpretation. So you are correct if you use Rome. This is respiratory alkalosis with what's it called, hypoxemia. So this patient most likely is in respiratory failure. Do you understand, guys?
Yes, thank you, doctor.
Good. Let's see if we can interpret. Oh, this one here. Okay. Anybody want to try this? What's your impression? Mrs. BD had these ABG results. pH 7.48, PaCO2 28, bicarbonate 22, PaO2 85. What is your impression? Anybody apart from Mary Kay? And guys, on this lecture, let's talk ketamine.
Yes, Doc.
Yes, please, what is your impression of this ABG result?
It partially compensated the respiratory alkalosis with mild hypoxemia.
Hey, this guy. So you are saying it's a partially compensated what? What is the primary disorder here? Hey, where's my guy? Ketamine, where are you?
I made that.
Tell me, what is the primary disorder that is being trying to be compensated? It's not fully compensated. I agree with you, partial compensation. But what is the primary disorder that you think we're trying to compensate here?
It's alkalosis.
What alkalosis? Respiratory or metabolic?
Respiratory.
Respiratory alkalosis.
Yes.
Okay. And what is trying to compensate? Why do you think there's a compensation going on here?
Because there is a mild, that carbonate is compensating with low. So
yes, yes, bicarbonate is getting low. All right. We have respiratory alkalosis. So bicarbonate is getting low. All right. To try to compensate. Correct. Partially compensated respiratory alkalosis with some degree of hypoxemia because PO2 is less than 95. Do we all agree with him? Jemo, GVA, Petra Diogo.
Yes, doctor, I do agree.
You agree?
Yes, I do.
Okay, great. Rauna Nashiveli, Shunguleni. Do you agree? Okay, they're not here.
Yes,
Okay. Let me see. Okay, you know, so all these ones are there. So just causes of metabolic acidosis can be anion gap and all that. So you read it. Any question? Just to go over that. Any question? Because
No questions, Doc. Thank you.
okay, so we understand it. Yes, and for your information, the department has agreed for your test to be written on the 17th of October, but it's going to be in the afternoon so that clinical work would have been concluded, especially by Dr. Chris and Dr. Peter. They actually requested for the test to be done in the afternoon. Okay, so please pass the information over to your classmate, all right? Your test, your end of rotation test would take place on the 17th as requested by your class. Am I correct? Was that not what you requested for?
Yes, thank you, doctor.
Okay, let's see if I can quickly see your past questions. Let me see if we can just spend some time.
And doctor, will you also please send us the acid-base presentation?
It's there, I sent it to you.
I don't think it was there with the when you send those many presentations. It's not one of them. If you can please send that one as well.
Mary Kay, I sent it to you in your year 4. Where are your lectures?
Okay, thank you, doctor. I'll double check.
Yeah, double check. You know, I remember I was the one that gave you this lecture, so I sent it then. Check. But if you check, yeah.
I'm sorry, Doctor. Has there been any updates or alterations on the acid-base presentation? Because I went through it now quickly, and there were some slides that you showed in this presentation that weren't there in the year 4 presentation.
Okay. So you are supporting Mary Kay that I should send this one too.
That would be kind. Thank you.
Okay. Mary Kay, you won.
Thank you, doctor.
Yeah, but let me see. I'm trying to see the last test you did. Okay, end of. Let me see. Okay, so I don't think I'll be able to show this one. Okay, for instance, from the lecture we had on local anesthetic agent, which of the following local anesthetic agent is most protein bound? Are you ready? Which of the following local anesthetic agent is most protein bound? A, mepivacaine. B, prilocaine. C, bupivacaine. D, lidocaine. E, procaine. Quickly. What's the answer, guys? Are you guys here?
C, bupivacaine.
Bupivacaine, correct, correct. Please increase your volume so that we can hear you. Bupivacaine, correct. All right. Okay, I think we did this last time, did we? Yes, I think we did. Let me see. All right, the normal tidal volume range during quiet breathing is the normal tidal volume. Did we do this? I think we did. I think we did. Let's go to. A patient on mechanical ventilator is suspected to have developed a pneumothorax. What is the definitive management for this patient? A, needle decompression. 2, normal saline fluid bolus. Tube thoracostomy decompression. Reduced PEEP, applied CPAP. What's the correct answer?
Tube thoracostomy decompression.
Correct. Tube thoracostomy decompression, correct. The following are absolute indications for controlled ventilation in the ICU, except absolute indication for controlled ventilation in the ICU, except A, C-spine injury with affectation of the phrenic nerve. B, respiratory failure with raised PaCO2. C, neuromuscular diseases. D, flared chest. E, hypoxemia. Correct answer is what?
Respiratory failure with increased CO2.
Wrong. Wrong. Think about the question again.
C, muscular diseases.
No. You want to, patient with muscular, let me knock them out. Respiratory failure with PCO2, the patient requires controlled ventilation to blow off the CO2. Neuromuscular disease, this patient cannot breathe on his own, so it requires controlled ventilation. Any other attempt? Flared chest, you need controlled mechanical ventilation for flared chest. So the patient to be breathing and have what's it called? Injury of the lungs by the flared chest, by the ribs. So the answer is hypoxemia. You don't need to do controlled mechanical ventilation for hypoxemia. You can give oxygen via face mask, via your venturi mask, and all that. Do you agree?
Yes, doctor. Just to confirm, so the answer is flared chest or hypoxemia.
Hypoxemia is the only one that is not an absolute indication for controlled ventilation.
Okay, thank you, doctor.
The next one, Mapocin E breathing system A is not efficient for spontaneous breathing. It's used in children less than 25 kg body weight. So which of the following is correct? Okay, that's what we're saying. Which of the following is correct for Mapocin E? All right. Number A is not efficient for spontaneous breathing. B is used in children with less than 25 kg body weight. It's also known as McGee's circuit. Has a reservoir back connected to it. Has a high resistance to gas flow. Which is the correct answer, everybody? What's the correct answer?
It's used for children less than 25 kilograms.
Beautiful, correct answer. All right. Which of the following statement is true concerning the reservoir bag in anesthetic breathing system? Which of the following statement is true concerning the reservoir bag in the anesthetic breathing system? A, it comes in only one universal size. It can be used for delivering intermittent positive pressure ventilation. C, it serves to vent out excess gas. All right. The bag's efficacy decreases with an increase in volume. E, it is color coded. So which of these statements is true concerning reservoir bag?
C.
Sorry?
C.
No. You have pediatric reservoir bag, you have adult reservoir bag. So it does not come in only one universal size.
B.
C? No?
Yes, C.
No, it doesn't vent out. That's what we use to vent out excessive gas. Your APL is what you use.
It creates an intermittent positive pressure.
Beautiful. It can be used. That's what we use when we say you are bagging the patient. You include it and you can bag the patient. So it can be used to deliver intermittent positive pressure ventilation. All right, which of the following gases is supplied at a pressure of 7 bar from the pipeline gas system? Which of the following gases is supplied at a pressure of 7 bar from the pipeline gas system? A, oxygen. B, nitrous oxide. C, compressed air. D, carbon dioxide. E, nitrogen. Which of them is supplied at the pressure of 7 bar from the pipeline gas system? Any answer, any attempt? Any attempt? Everybody has gone quiet. Vicos, Mary Kay, what's the answer?
So
I'm not sure, Doctor.
Okay, someone want to answer? Visco is not sure.
Yes, I'll be guessing. I will go with nitrogen oxide.
No, the answer is compressed air. Most of them are supplied at 4 bars. Compressed air supplied at 7 bars. Okay. Are you taking note of the answer, people?
Yes, Doctor.
Which portion of the cardiac cycle has the highest myocardial oxygen consumption?
No.
Hello? Is somebody saying something? Rauna, Ruaha, sorry, Nashivili. Are you saying something?
No, Doctor.
Okay, I can see your picture displayed there. Okay, let's go. Who has the answer to this question? Did you get the question?
No, Doctor, can you please repeat?
Which portion of the cardiac cycle has the highest myocardial oxygen consumption? A, injection. B, diastasis. C, isovolumic relaxation period. D, isovolumic contraction period. E, left ventricular diastole. Which of them has the highest myocardial oxygen consumption?
Contraction, maybe?
The answer is D, isovolumic contraction period. Correct. The name of the long volume at passive end expiration is called what? At the end of passive long volume at passive end expiration is called what? Total lung capacity, functional residual capacity, reservoir volume, expiratory reservoir volume, and tidal volume. Which of them? At the end of normal breathing, what is the name of the lung volume?
It's functional residual capacity, Doctor.
Beautiful, functional residual capacity. What is the commonest type of kidney injury associated with non-steroidal anti-inflammatory drugs? What is the commonest type of injury associated with non-steroidal anti-inflammatory drugs? A, acute intrinsic kidney injury. B, pre-renal injury. C, glomerulonephritis. D, acute tubular necrosis. And E, post-renal obstruction. Which is the answer?
Tubular necrosis.
Sorry?
Tubular necrosis, Doctor.
No. You know, that's why the answer is pre-renal injury. That's why before you give your answer to patient, you need to be sure that the patient is adequately fluid resuscitated. Okay. Your patient should be adequately fluid resuscitated. Which of the following blood products can be administered to reverse the effects of aspirin therapy in a patient? Which of the following blood products can be administered to reverse the effects of aspirin therapy in the patient? A, protamine, B, vitamin K, C, von Willebrand factor, D, platelets, E, red cells. Anyone? Any attempt?
Dr. Maidol,
Platelets.
can you repeat the question?
Which of the following blood products can be administered to reverse the effects of aspirin therapy in a patient? A, protamine, B, vitamin K, C, von Willebrand factor, D, platelet, E, red cells.
Oh, platelets, doctor.
Platelets, correct, platelets.
Doctor, sorry, I have a question on the previous question regarding the most common renal injury caused by NSAID administration. If the answer is pre-renal injury, that means that there is already, like you said, a reduced blood supply, or yes, blood volume that's decreasing cortical perfusion of the kidney. But in that case, it's a pre-existing pathology that's aggravated by the NSAID and not caused by the NSAID.
Yeah, I see your point, but you see, the thing is, if your patient is, renal, acute kidney injury can either be pre-renal, renal, or post-renal, isn't it?
Yes, yes, doctor.
Most of the commonest ones is the pre-renal, all right, which can most of the time due to hypovolemia or hemorrhagic shock, fluid depletion, and all that. So
yes,
when you're giving NSAID to this patient, all right, the presence of the what's it called, of the hypovolemia will predispose the patients to acute kidney injury, which is pre-renal. Renal,
yes,
and all that are most likely are due to antibiotics that results from glomerulonephritis infections, glomerulonephritis and infection. All right, so it cannot be glomerulonephritis, acute tubular necrosis, or acute cortical necrosis. These are, secondary to some antibiotics, like, and that's why when you're given such antibiotics, you will renally adjust the doses. All right, so it's safer to say that pre-renal is the commonest type of kidney injury associated with NSAID. I agree with you that the question may not be too self-explanatory, but I'm sure that when you're giving the lecture, the emphasis was made on hypovolemia, hemorrhagic shock, volume depletion in the presence of NSAID causing pre-renal acute kidney injury.
Mm-hmm. Okay, doctor. Now, furthermore, another question, or rather a statement. I'm not questioning what you are saying. I'm just trying to make sense. The mechanism whereby the NSAIDs cause injury in pre-renal injury is by further reduction of cortical perfusion.
Yeah, perfusion, yes.
Yes, but then the thing that happens as a result of that is tubular necrosis.
Okay.
So the question is a bit, the answers provided are a bit dichotomous.
Yes, I understand you. But what we're trying to say is that is reduction in renal perfusion.
Yes.
Which it could be reduction in cortical or tubular perfusion.
Okay, I understand.
Is the perfusion that we're actually looking at. And when we are talking about perfusion, we're talking about pre-renal state.
Okay. In that case, I understand, because it may not be to the extent of tubular necrosis.
Yes, is the reduction in perfusion.
Okay. Thank you, doctor.
Yeah, but I appreciate it's engaging. Your question is engaging, which I think is something all of us can benefit from.
Thank you, doctor.
Okay. I think we have 9 minutes more. Which IV induction agent will be most appropriate to use in a hypovolemic patient? Which of the following IV induction agents will be most appropriate to use in a hypovolemic patient? A, propofol, B, terpentum, C, ketamine, D, etomidate, E, midazolam. Any answer?
Ketamine.
Ketamine, correct. Correct.
Doctor, I have a question. Etomidate
Yes.
would also be able to be used, isn't it?
Etomidate is cardiostable. All right. What it means is that for patients who are not hypovolemic, it will cause hypotension. Unlike terpentum, propofol, all those ones will cause hypotension even in a euvolemic patient. All right. But etomidate will not, it's cardiostable, I agree. But in the face of an existing hypovolemia, maybe from blood loss or from GI losses, you want to use ketamine because ketamine is cardiostimulatory.
Okay, doctor, thank you.
Do you get the answer?
Yes, doctor.
Okay, great. Okay, indication for endotracheal intubation includes the following except. Indication for endotracheal intubation includes the following except: 1, to maintain patient airway, to protect patient's airway, to provide positive pressure ventilation during lithotomy position and during prone positioning. Which of them is correct?
Lithotomy position.
Correct. Regarding cricut pressure, which of the following is correct? Regarding cricut pressure, which of the following is correct? It requires a constant 30 units of applied pressure. Forget this question. Which of the following is an example of fixed performance oxygen device? Which of the following is an example of fixed performance oxygen device? A, NASA prong, B, Venturi mask, C, non-rebreathing mask, D, partial rebreathing mask, E, surgical face mask. Which of the following is an example of fixed performance oxygen device?
Venturi.
Talk now. Who is this person that is talking with a slow voice? I want to hear your voice.
Venturi.
Venturi mask, correct. Okay. Yes, I think I'm done here. All right. All the best in your test on the 17th and your exam, all the best too. If there are no concerns, can we call it a day? Or if you have any concerns, I'm here to address them.
Thank you very much.
Sorry, Doc. Thank you. And we just want to make sure whether we'll be meeting you next week.
Next week is what date?
It is, just quickly check, be on the 15th of October. But we also have a lecture with Dr. Bwambo at 8 o'clock. I think it will be around up to 10 o'clock. So if we are meeting you, will it be possible for us to meet you perhaps an hour later?
Okay, I will see. I think I'm actually exhausted on my stuff, but we'll see how it goes. We'll communicate before then.
Okay, thank you so much, Doctor.
17th is on Monday, isn't it?
Yes, Doctor. It is not this Monday, next Monday, the Monday after that.
Yes, okay. And your exam timetable is out?
The final one has not yet been shared with us, Doctor, but they have shared a provisional timetable.
Okay. When is your anesthesia for the provisional timetable?
I'll just quickly make sure.
Okay.
17th of November, Doctor.
17th of November. Okay.
Yes.
So you have time after the test to at least also prepare, isn't it?
Yes.
All right. Have a wonderful weekend. Make sure you study and be the best in your coming exam. Okay.
Thank you so much, Doctor.
You're welcome.
Thank you, Doc.
Bye.
Bye-bye.
Thank you, Doctor.
Bye.